What we're going to be doing now is a session called The Conditions for Success in Digital Health. I'm going to be moderating the next 3 sessions as well. So I'll be keeping an eye out on the chat that's going on there. Lots of rocket ships and snowballs going on. So let's do that. Luke, you're going to have to count them up. I'm sure Foxo's got the ability to count emojis, so you're going to be counting the amount of snowballs for today. That's the forecast is there, so let's do it. I'm going to bring, actually I was going to bring the moderator on the stage, but that's me. So this session today is called The Conditions for Success in Digital Health. There's no shortage of strategy and vision in digital health. We've talked about some of the lofty ideas and concepts, but the fundamental baselines and the requirements need to be established before we can start building on these aspirations. So we're going to be talking about some of that today. I'll bring onto the stage our speakers for the session. We've got Berne Gibbons, George Margelis, and Tim Blake. And I'll just move the little animated picture there that's in the way. So there we go. Cool. Hi guys. How you going?
Good.
Hey.
Good to see you.
Great. Let me give everyone a bit of an introduction. So Tim Blake, he's the Managing Director of Semantic Consulting, which is a firm focused on leading digital change in healthcare. Tim has been featured on the podcast in episode 2, in episode 50, and episode 150, which just got launched publicly today, by the way. So he's got the hat trick of episodes. So do check that out. And actually, in all seriousness, Tim's support has helped get Talking Health Tech up to where it is today in the very early stages. So very much a personal line with what we're trying to do. So thank you for joining. Berne Gibbons as well, big advocate for Talking Health Tech, but she's the head of business, innovation and partnerships at Informatics. Bernie's committed to advancing digital health in Australia and driven by a desire to educate and inform the current and future healthcare workforce. She's an active THT Plus member. She's a former member of the month for Talking Health Tech as well. So yeah, I remember that one as well. And she's moderated a session on telehealth at the Autumn Summit before and featured on episode 78 of the podcast as well. And as well in this conversation, Dr. George Margelis, independent chair of the Aged Care Industry Information Technology Council, strong experience in software development, marketing, and interest in improving quality and delivery of healthcare utilizing information technology. He's a THT Plus member, active in the community. He's appeared at networking sessions and on episode 130 of the podcast, which you can listen to as well. Actually, a lot of people that still gets a lot of downloads, that episode. A good context in terms of aged care, healthcare, clinical governance, definitely one to listen back to. So, this session today is about the preconditions for success in digital health. And actually, speaking with 3 people who've got a lot of background, and this conversation deserves much more than 30 minutes, but it's a good teaser to some of these key points. And it started really as a conversation that Tim and I were having in the early stages about, what's to happen. So it'd be good to, build on some of those ideas. Tim, look, people can listen to an episode that just got released today of the podcast to get some more detail, but set the scene for us. Why is it important that we're focusing on the conditions for success in digital health, firstly, from your perspective?
Yeah, thanks, Pete. Look, I think as I work with a number of different health organisations around Australia, what I tend to see is organisations who often have their wheels spinning. They're trying to implement digital health, but sometimes the traction they get, the adoption that they have, the enthusiasm, the incentivisation amongst clinical communities for adopting digital health can be a really mixed bag and often is quite limited. I think we have to remember as we start the conversation today that obviously it's so wonderful to see so many clinicians involved in this community. And I think Berne and George would agree there's a huge increase in that proportion of clinicians involved in these conversations compared to even 5 years ago. Yeah. But at the same time, there is a big skew in that audience to people who are enthusiastic about digital health already. And we have to remember that the bulk of the workforce, if you see it as kind of a normal distribution, the bulk of the workforce are not particularly enthusiastic about digital health. Where we're at in our digital health journey is we're seeing some wonderful innovation, and it's quite possible to have successful pilots around digital health innovation, and we've seen a lot of that. But to transition from pilot to systemic use of digital health across an entire region is not something that we have seen a lot of success in at this stage. So going from a small group of advocates who are already on board to bringing everybody on board, even when people are not necessarily enthusiastic, what do we have to do in order to make digital health systemic and not just continual pilot after pilot after pilot, proving successful things but never scaling up. So that's really where this conversation came from, and some experience I've been having over the last 18 to 24 months of trying to scale innovation up and realizing that some things weren't actually in place.
Yeah. And so, Bernie, a lot of nodding of heads, from both of you, but Bernie in particular, and seen you, speak a lot about the need for, the interoperability side of things. Telehealth, big advocate for that and everything. So you're finding as well that, is it similar to what Tim's saying in your perspective of, pilots and kind of kicking of the tires, but no real kind of buy-in and urgency to do something relating to technology in healthcare?
I think that, not only do vendors and, software developers not want to do pilots anymore, the sector doesn't want to do pilots. They know exactly, and there's people in this in the audience I've seen today that that will agree that, you don't do a pilot. We know what happens to them. They go nowhere, and they're quite often born from, a need. We know that we want to do this, so perhaps if we just have a look and we see how it goes, and everyone says no, we're not enjoying it, and so it doesn't go anywhere else. But I think the co-design, which is something that at Informatics that we are just all about, is not just talking about co-design, but actually bringing the clinicians in, not just to tick a box. And Tim and George and I were just talking about this out the back. It's not just to tick a box. It's actually the only way you're going to get true. That's right. Yeah. And they don't have jobs anymore, Rob, either. But the only way that you're going to get true adoption is to actually think of the nurses, and the clinicians and the allied health, have them all at the table. I've never understood, Pete, why we don't just invite everyone straight away. I always have this vision of a big round table, and we're all sitting around the table and all just saying, this is what I want, this is what I want, and then you write it all down, and we go away and we develop it, and guess what? It's used. Because it actually, as an old ex-nurse, I don't want something that just looks like it's, something totally, foreign to me. I want to be able to look at a chart when I go into the hospital that I'm working at that night or day, and just be able to say, oh, everything's still in the same place. But then what do you do with the data, of course? So, another very good, I suppose that's the important part. We've got all this data now that we know that the Russians and the Chinese and everyone on the dark web will pay a lot of money for. How do we keep it, let everyone know that your data is actually safe?
Oh, look, that's a really important topic that we will cover a lot in the next session too. But I wanted to build on some of that. For George particularly, a lot of experience in healthcare, and now obviously big focus on aged care with the Royal Commission, but also just previous to all that as well. How does some of this relate from the healthcare side of things into aged care and what needs to be done now, and the conditions for success in that space?
Cool. Well, first of all, look, I'm not quite as pessimistic as the other two. I think that having first put on a white coat in 1979, there's been a huge change in what's happened in healthcare. So whilst, yes, it may not be going at the speed many of us would like it to, and I must admit, 30 years ago, I was a bit like Tim, sort of saying, hey, do it now, do it fast. But having watched what's happened in the space over 41 years now, we have seen continuous improvement and continuous change. Not perfect, but hey, it's a lot better than what it was 40 years ago. And also, the people we are dealing with now are a lot more complex. When I first stepped into a hospital in the early 1980s, we weren't managing people with frail elderly with sarcopenia and 7 comorbidities. That just wasn't happening. So the reality is that we're having a much more complex environment now. we've had some really positive steps. I mean, I still remember having to run down to the pathology department every hour on the hour to get pathology results. So the fact that I can now get those on my phone at the bedside is an amazing change. But the reality is also that we have to understand within the context of the whole healthcare system, digital health is a component. Yes, it's a very important component. It's very important to us because it pays for our mortgages. But there is so much else happening in healthcare that needs to also happen. And classic example, I mean, we're in aged care at the moment, we're looking for more money for improvements, and we've just had the announcement of a new Alzheimer's drug, which is going to cost $2 billion a year to deliver. How do we prioritize that sort of expenditure? So, we are getting there. We are doing things. Incremental change, unfortunately, is the way forward in healthcare. Big bang change just doesn't happen because of the risk-averse nature, and Melanie Tan touched on that earlier today. But let's be positive that we have made a significant improvement in the quality and safety of healthcare in Australia. More to be done. Persevere. That's all I can say to everyone out there. Just keep on going.
Yeah, interesting. And hey, going back to you, Tim, for a second, just and building on that, thinking about what's changed in the past 40 years, I guess, would be the need for more technology and the not just the fact that it exists, but then the utilizing it and accepting it. And we spoke a bit in the podcast about digital literacy and data literacy of providers, and also, I guess, the maturity of those as well too. How important do you see these factors in what you're doing, the work you're doing with your clients?
Yeah, look, and I want to clarify based on what George said. I think we are making steady incremental improvement. I think there's a question here about whether consumers themselves will tolerate incremental improvement or whether there's an expectation of more. And I think we will be dragged kicking and screaming towards quicker change. I guess my observation, as I've dealt with probably hundreds of clinicians face-to-face over the last 18 months, is that we make a number of assumptions, particularly about the digital literacy of those communities. Now, again, we have to remember that the group that's on this call, by definition, is much more digitally literate. I'm talking about workforces that are often out in rural and remote areas. And the demographics of those groups are often such that they're female, typically over 50, and not very digitally confident. And yet, when I look at our communications approaches, when I look at our change approaches, we often, not always, but we often have a one-size-fits-all approach to training materials that assume a certain level of digital literacy that's not true. Someone in my team last week was teaching the practice manager at a progressive GP practice how to copy a URL into a web browser. That is not untypical for the experience that we have. We cannot expect that people would be able to utilize sophisticated digitally enabled models of care if we don't have basic digital literacy. But then as you deal with the organizations responsible for that, a lot of people would go, well, it's not my job to deal with that digital literacy. And so we have to think very carefully about how we maybe take a couple of steps back in some instances if we want to roll out digital health technologies on a very wide basis. And we need to be careful that we don't exacerbate existing digital divides by only enabling practices that want to be enabled and then leaving the others behind. We have to be careful with that. So increasingly in the strategy work I'm doing with my clients is going back to digital literacy, just fundamental IT usage, and making sure some of the health workers we're dealing with are confident in that space, so we can bring everyone up to a similar level and not just enable a small group of already enabled people.
Yeah. There's some good comments, happening in the chat there, which we'll, continue to look in the on the screen there. But just to Berne, with informatics particularly as well, helping originally healthcare providers move, from paper forms and, just utilizing paper forms and digitizing those, and now to a point where, then digitizing that information even further and bringing it cloud-based. I would imagine bringing those end users along with that journey, to keep the pace of the innovation of the technology is really important, what you do as well.
Yes, absolutely. And I'm just not pessimistic, George. And yeah, I'm not too thin-skinned, but I don't think Tim and I are pessimistic. I actually think we're more realistic, actually, as to where we are. You know, when you, and I'm looking at what Lambo's written here, you know, about, you know, being divorce specialist. I hope that wasn't for you. I think it might have been for Amelia, but I hope everything's okay. But, you know, to only have one that's sending, you know, reports digitally. You know, St Vincent's Hospital here in Sydney, you ring them to make an appointment and they say, can you fax your fax or take a photograph of your referral letter and send it to us by email, and then we'll they print it off and you get to sign your documentation when you arrive there. And I mean, David Roth would, you know, I mean, I don't think that was the future that he saw at the time, you know, for where we would be now in 2021 with digital records at St Vincent's. So, mind you, we're about to roll out in there, so things are going to get better. But you know, the thing I suppose that, you know, we've been through is this time between maybe, when was it? 2008, George, we were selling telehealth solutions, or trying to anyway, a great big device that was going to sit on desk. It just had a phone, but, you know, this was what we were going to do, and this was going to save, you know, people out in rural and remote areas, people in aged care facilities. You still can't get the doctors to use a video in telehealth. Why? Because we haven't brought them on the journey with us. So I think that the future of digital is to do, you know, gather people together and actually ask them, what do you want? And then we just turn around and we go and develop it, and we go, how does this look? Will you use this? No, it needs this. You know, we've got to move up out of the building of where we were just looking at paper records down, you know, in medical records, and say, okay, still very important, but nurses, what do you want, so that you'll actually start to use these things and see them as meaningful?
Yeah. There's a lot of walking before running and getting those basics and fundamentals right.
Yeah. And look, and they're right. I mean, the key thing is, of course, is that we've progressed the technology but not progressed the workforce. So how do we actually get the workforce to follow along and play a more active role? And yeah, we're exactly the same challenge facing us in aged care. We've got an edict from the Royal Commission telling us to digitise by the middle of next year, and a workforce who doesn't have any idea what technology means. So, you know, throwing technology at a workforce who can't use it will lead to the ultimate result that no one will use it. I mean, it's no surprise. So Tim's point is relevant. We need to get the workforce actively engaged, digitally enabled, understanding, but a lot of that comes down to them understanding the value as well, not just saying technology for technology's sake. And I think that's where we have to really drive an education campaign.
And one of the things we've done in response to that, George, as we've learned, and this is far from perfect, but I think it's a step in the right direction, and I talked about this on the podcast with Pete, is develop a digital health maturity assessment that puts people into different tiers, that reflects not only their technology usage, but also their motivation. And then treat those groups differently. And we treat them differently, not because we want to reward those that are doing well and punish those who are doing badly, but actually the opposite, and give more specialized attention to people who are at low maturity. And what we're finding is those groups often need more help with understanding, why are we doing this? What is it for? What does it mean? They need more face-to-face interaction. They need more convincing. And then we can start to bring them on the journey of using the technology, but we have to have the motivational conversations first. Absolutely. Those who are on the mature end tend to need information, access to learning, but need less face-to-face. Ideally, we'd give everyone face-to-face, but they need less face-to-face, more access to information. So what we're trying to do is build change toolkits that are customized to the level of maturity, and also protect people from themselves, because what we found in a few instances where we had very low maturity practices who wanted to implement digitally enabled models of care, and we had to have difficult conversations with them and say, you're not quite ready. If you're still writing on paper cards and you don't want to use the My Health record and you won't use secure messaging, then you're not going to be successful in doing this. We need you to get to a certain place first before you're going to be successful. So let's work with you on that. And I think we need more of this approach as we look at the workforce and what it needs. And some of these conversations are going to be frustratingly basic. And we as technologists want to be running off doing the AI and all of the exciting things. But we need to focus a lot more on some of these basics, or we're going to leave the workforce behind.
There's a comment that Rich has made, as a GP operating in the space, there's the element of who pays for some of the work there and issues with interoperability. We can talk a bit about that. Also, in terms of interoperability, I think there's twofold, not just the payment side of things, but also, that interoperability by definition requires providers to be working together. And that, if we're going to have a seamless ecosystem where information can flow within it, then there's the need for the ecosystem to be working together. But often that clashes with, the commercial nature of technology solutions having a viable business model, right? So, how do we strike that balance or actually progress with this kind of, we're kind of stuck in this cog where no one wants to pay for it, and the clinician and vendors kind of don't want to work with each other, but in the end, we've got to solve a problem. I'm not sure if there's a kind of slow way forward out of this. I'm not sure. George, do you have any thoughts on this?
So look, we talk about technical interoperability, and I agree there's a lot of work to be done there. But the reality is, in healthcare, we don't have an interoperable workforce culture. Yeah, back when my days, the doctors only spoke to the doctors, and the nurses only spoke to the nurses, and allied health were way out. Now that has improved over the years. We now do have multidisciplinary teams, so we are starting to get more interoperable as a care provider community. The consumer or the patient still isn't quite involved enough, and that's something we need to significantly work on. But the reality is that until our culture becomes interoperable and supports that model, then there's no use actually making the technology interoperable, because we're not going to use it. So we need to work on the culture, which goes back to the discussion we were having earlier about enabling the workforce to understand how this works and giving them cause to do so. Getting past that role, once you start delivering and demonstrating the value of the outputs, then you start getting that sort of on building of usage. So it's a slow, tedious process, and it needs to sort of be experienced. But the key thing, like I said, is I still go back to the technology is 25 years ahead of the culture. We need to get the culture to catch up with the technology, and once we've got them both in sync, we can then start doing some really good stuff with it.
Can I just add that?
And you go, and then go.
I think that there's something that's really important that we need to take into account, and is the patient-led healthcare needs to. There's an expectation that we would already have the information about them that we've already shared. So I'm talking about interoperability naturally. But, they think that by the time they get to the hospital, well, don't you already know what is in the record that my GP has on his desk? And I see someone, I think it was Josh Case, who said, who is going to pay? I think that everyone is paying enough already. Richard, sorry. I think that there needs to be, just as vendors, we need to just say we want to interoperate with these other systems to make our the data that we're holding more meaningful to the end users, to the patients.
Yeah. Hey guys, we're going to have to wrap it up in a minute, so I'm going to give you a minute or two each to kind of close out. Tim, look like just to close out that thought.
Well, just on the question of who pays, because I think that's really important. I think it's also who takes the risks and who gets the reward. We are a captive to a fee-for-service health system that has very little incentive to adopt digital health. So often the mantra I hear in primary care is, well, where's the MBS item for that? And that inevitably lags innovation by a number of years. we are screaming out, not just because of digital health, just fundamentally, structurally, the way we pay for primary care is quite broken. But with digital health as well, we are screaming for a value-based healthcare system where people have incentive to use innovation because it drives safety and quality, and because there's a risk-reward equation that can pay off for them. So I think the question needs to be a little bit more sophisticated than just who pays, and I'm sure that's what Richard meant. But I think we need to be looking towards value-based care as a way of getting a more equitable distribution of risk and reward, and really incentivizing innovation in digital health.
Hey, look, George, I'll give you an opportunity to close out. Any final thoughts? I can't believe that's 30 minutes already. I feel like we could talk for another 4 hours. But George, any final thoughts before we close out this conversation?
So basically, I'd say, look, yeah, we've done a pretty good job in healthcare. We've got a real new opportunity now in aged care. There's funding in place. There's passion for reform. There's opportunity. Call out to the healthcare people, come and give us a hand in aged care to make sure we get it right faster this time. And yeah, look forward to working with you all.
Yeah, a lot to do. But look, we're going to have to close it out there, guys. Look, thank you so much for joining this conversation. I'm sure we'll continue the conversation further on another episode of the podcast or in the community. So thank you so much.
Thanks, everyone. All the best.